Hello, everyone. My name is David Zuckerman, if I could come into focus, and I'm happy to be here for our MSNTC overview of brain metastases lecture. We're kicking off strong with the brain metastases block, and I'm just going to start here with some slides. But first, I will turn my camera off just so that I don't lag. Okay. All right. So welcome everybody again to our brain tumor metastases block 2. So today we're going to be talking about the overview of brain metastases, and we'll be sticking to our regular Tuesday at 8 p.m. Slot. Next Tuesday we'll be talking about management. The Tuesday after that we'll have our journal club, and then the Tuesday after that in April we will have our grand rounds. And one of our sessions coming up, I can't comment on this specifically, but Dr. Rad is going to be talking about is demon possession real? And that'll be happening tomorrow at 7 p.m. Eastern. And Kyle and the Neurosurgeon's Journey group are going to be talking about global neurosurgery, and that's going to be happening this Thursday at 7 p.m. We also will be having the Neurosurgery Journey live every Thursday at 7 p.m. Eastern, and that, again, is that session on global neurosurgery. That's what they're covering on Thursday. And then we also have our patient and family service program. We have an upcoming meeting for that on March 24th. Definitely check out our website for more information on that. I believe Dr. Rad will be helping with that. And of course, our video library has recordings from webinars like this one, and it's a wonderful resource for your neurosurgery education. So check us out on YouTube. We're 10,000 plus subscribers strong. Definitely subscribe if you like our content. And I would like to introduce our esteemed guest for the night, who is going to be discussing the overview of brain metastases, Dr. Mohammed Fouda. And so, again, just a brief introduction. Dr. Mohammed Fouda is a neurosurgery fellow at Weill Cornell Medical College. After completing his medical degree from Ain Shams University, Faculty of Medicine in Egypt, Dr. Fouda continued his training as a neurosurgical oncologist at both Johns Hopkins University and Harvard University. His main areas of interest are the development of new devices and prostheses to improve neurosurgical procedures in adult and pediatric patients. So without further ado, Dr. Fouda, thank you so much. The floor is yours.
Yeah, thank you, David. And yeah, thanks for having me tonight. And I hope it will be like an informative session and to pave the way for the upcoming sessions as well. So this night today will be like focusing more on the epidemiology of brain metastases and the main shortcomings in this like very common malignancy, but it's very hard to report. So I'm going to share my screen now. Just let me know if you're seeing it well.
Yeah.
So do you see it now?
Yep, we see it perfectly.
You see the full screen, not the other screen, right?
Yep, just the full screen with the slide.
Okay, perfect.
Yep.
So I think just a little brief introduction about like what's brain metastases. So it's one of the most common intracranial lesions in adults, and represent like the major cause for morbidity and mortality as well in almost 20% of adults with primary cancers elsewhere. So the annual incidence is about like 10 per 100,000 patients, and it's believed that this incidence is increasing recently because there are like advancements in treatment, neuroimaging, and also like the overall survival for these patients is increasing. So all these factors contribute to the increasing like in the incidence of brain metastases. This for the rising number. And the major issue that we have in the epidemiology of brain metastases that we have lack of systematic reporting. So unlike the primary CNS lesions, primary CNS lesions has to be reported to the national registry, like the SEER or like the US Central Brain Tumor Registry as well. But for brain metastases, you are not like supposed to report these lesions, and so it's very hard to know like the real incidence and the real numbers behind it. So there are like three types of studies that I want to discuss with you today. So there are like the population-based studies and the hospital-based and the autopsies. In the last 20, 30 years, there are like major 4 studies, which are population-based studies, one from Finland, another one from Iceland, Minnesota, and the National US Survey of CNS tumors. The major observation here is like the numbers are very varied. So there is a wide variation in the reported numbers and the reported incidences. And like the reasons behind this could be because like there are different systems for data collection, accuracy of the data. Some studies report brain metastases based just on imaging or like how they look like or how the patient clinically present, and other studies report them based on the pathology and like it has to be pathologically confirmed. So that's could explain the variety and the wide variation in the numbers from 2.8% to almost 50% in the US survey. The hospital-based studies, it's pretty much reporting the same numbers and the same like incidence, ranging from as low as 3% up to 50%, and they share the same numbers as well, but it may be like carrying some degree of inherent bias as well. The autopsy, it's not that common right now, so almost like less than 5% of hospital mortalities will go for autopsy. So autopsy is not that much a significant contribution for the numbers and the incidence at the moment for brain metastases. Unlike what happened like years ago, there was like a huge study in 1978 that reported that autopsy papers that almost 25% of patients with primary cancer had like brain metastases in their autopsies. But now it's not that common to do autopsy for patients like this because it's already diagnosed. Trying to deal with the shortcomings in the epidemiology, like data for brain metastases, there are 2 basic models that have been like the landmarks epidemiology studies for brain metastases. It started with the Swedish model, which is a very major study that came out in 2009. A team of Swedish researchers, they built a registry for the brain metastases, and they included every single patient with brain metastases all over the country. They consider this study as one of the most accurate studies when it comes to brain metastases epidemiology because it's a very, very like well-established system. So first of all, the healthcare system in Sweden, it's kind of governmental operated system. So every patient has the same standard quality of care. So there is no difference between the patients and there is no difference between how they treat one from the other. The other thing could be that all patients admitted to hospital in Sweden, all of them have like a national registry number. So you cannot miss one patient because if there is a patient admitted anywhere in Sweden, this patient will be like assigned to a certain number that you can follow for the rest of his life. So it's very hard to lose any patient. The third thing that it's like when you collect these data, when you collect like the cohort, then you start following these patients for years. So it's a long-term study, long follow-up. You are not missing any patient. So the numbers, like we believe that the numbers that came out of this study are the accurate number. So they believe that the numbers jump from 7 per 100 to 14 per 100,000. And this is like a major increase in the numbers. Similar like model will be the Metropolitan Detroit Cancer Surveillance survey. It's a similar model to the Swedish one. It's only in Detroit. It enrolled more than 16,000 patients in 2 counties, and they are following this pretty much the same protocol of the Sweden study. But the numbers I think the numbers is about like 10%, like the annual incidence is 10%, which is pretty much close to the numbers in the Swedish study as well. So now, like, where are the numbers and location of brain metastases? So it's either like single or multiple brain metastases. So single metastases without evidence of a systemic malignancy are relatively rare. It's just less than 0.5%. But single metastases are found in 39% of patients, while multiple metastases are found in almost 50% of patients. For the location, because of the mechanism of the spread is like most probably it's hematogenous, so it's between the white-gray matter junction. So it's most commonly in the cerebrum and less common in the cerebellum and the brainstem as well. So it's almost less than 15% in the cerebellum and less than 3% in the brainstem. For the spread of the primary cancer to the brain, so as I said, like the major mechanism is the hematogenous is like root. So most brain metastases occur at the gray-white junction due to the hematogenous spread of the tumor emboli, which become entrapped in the small branches of the terminal arteries found at this junction. Some of these lesions as well, like it's not that common, but it could be a retrograde spread via the cranial nerves, especially in lesions which are like the primary lesion is a squamous cell carcinoma of the head and neck. And for the cancer cell, like 15% of the cancer cells are capable of metastasizing. So that's a pretty much significant number. Also, there is a molecular rule here in certain lesions. So for example, for the brain cancer, for the breast cancer, it's caused by a lot of dysregulation of various cellular signals like the PGF, beta, and the triple negative breast cancer has a higher chance for spreading to the brain. For melanoma, it's the hyperactivation of the PI3K and the KAT and mTOR signaling pathway represents facilitating process for the progression in the brain metastases formation as well. So these just there are a lot of things that we can mention here about the molecular rule specifically based on the type of the cancer, but this is just a brief thing because it's a major topic that we can talk about it separately in an entire session. But this is are the most common molecular things that we can mention. Lung cancer is the leading cause count for the most of the brain metastases came from the lung, followed by the breast, then the melanoma and renal cell carcinoma. So these are the most altogether represent 80% of the brain metastases. For the timing of the diagnosis, most of lesions, they are metachronous, which means they are diagnosed after the diagnosis of the primary lesion. Sometimes they are synchronous, which is at the same time, and rarely it's precocious, which is that you diagnose the brain metastases first before the primary lesion. Brain metastases coming from the lung cancer, it's more common in males, older males. It's non-small cell lung cancer is the most common to be associated with brain metastases in older patients and in male patients. That's why it's recommended to do brain imaging, like brain MRI, for patients who have lung cancer, because there is a very high possibility for them to develop brain metastases. So it's almost 80% of lung cancer patients will have the diagnosis of non-small cell lung cancer. And the median time to diagnosis is less than a year, so it's about 10 months. Breast cancer is the second leading cause. Unlike the lung cancer, it's in young females. Usually they are young women who has breast cancer and they're less than 35 years old. So it's completely opposite to the lung cancer. And it's more they found that patients who have HER2 positivity in breast cancer, they have higher chances of developing brain metastases. But surprisingly, the survival rate of the overall survival for these patients are better. So there's high chance for developing brain metastases in these lesions, but also the survival rate is better. Melanoma, it has high propensity for dissemination to the brain, so it's almost 90%. There's a study that came out years ago, showing that 90% of patients with melanoma, they have higher chance for developing brain metastases. The time to diagnosis, it's about 2 to 3 years. the risk factors including like male patient, ulcerating primary lesion, and melanoma of the head and neck. Also, brain metastases that are like that came from melanoma, they have higher chances for bleeding. So it's very common to see like hemorrhagic lesions or hemorrhagic brain metastases that came in melanoma patients. So what are the clinical symptoms and signs for patients with brain metastases? So it's obviously depend on the lesion, on the location. But these are the most common findings and the most common symptoms and signs that a patient could like present with. So it's either like high ICP, nausea, vomiting, headache, motor dysfunction, ataxia, visual disturbance, mental status alteration, cognitive dysfunction, seizures. All of them like depends on, for all of them, it depends on the location of the lesion itself. Here are some insights on the like the radiology of the brain metastases. So what we are expecting to see in a lesion, like in imaging of these lesions. So for CT, in this imaging, like we can see like an axial cut for non-enhanced lung contrast CT. You can see multiple lesions here. And on the left side, you can see enhanced like contrast CT axial cut as well, in the right frontal parietal lesion, and you can see like it's hyperdense in the CT with contrast. This is a T1 axial MRI with and without contrast of a very characteristic ring enhancement lesion here on the right side, and you can see the ring enhancement of the two lesions here, and it appears as hyperintense in the T1 non-contrasted MRI, and ring enhancement on the MRI with contrast. Also, as I mentioned earlier, hemorrhage in brain metastases, especially in melanoma patients, is very common. So this is a sagittal cut of CT showing like multiple lesions with extensive vasogenic edema as well. And these are all like hemorrhagic lesions. So the differential diagnosis include glioblastoma, brain abscess, subacute stroke, and meningioma. It all depends on, you can't just say it's brain metastases based on the radiology or even the clinical presentation. So you have to deal with it at an entire, you look at the full picture of the patient. So if like any other comorbidities, any other like family history of cancer, if the primary lesion is diagnosed or not, age, gender, as we mentioned earlier, like the gender play a major role in this, either like being a male in lung cancer or being female in breast cancer, and so on. So for the differential diagnosis, you have to just look at the full picture and not only the imaging. The prognosis and survival. So breast cancer patients with brain metastases have an average survival of 8 months. Lung cancer patients have a survival of average 6 months, and patients undergo surgery. And this is like controversial to a certain limit because there's no enough statistics to document this, but the average survival tend to be approximately 18 months, which means like the survival rate will be improving with surgical intervention. Favorable prognostic factors will be synchronous brain metastases, KPS score more than 70%, the RP classification 1 and 2, and patients who are younger than 65 years. So in conclusion, brain metastases represent a major cause of death in 20% of cancer patients. It may cause significant physical and financial burdens on patients and their families. The lack of unified national registry represents a major epidemiological obstacle for this in order to get more accurate data. Almost 80% of brain metastases come from the lung cancer, breast cancer, renal cell carcinoma, and melanoma altogether. Patients with primary cancer and brain metastases usually have metastases in other anatomical locations. And if you're just seeing one isolated lesion in the brain, you have to be suspicious and think about like alternative diagnosis. Thank you.
Thank you so much, Dr. Fouda. I'm going to come on screen here, but please let me know if I'm lagging at all, in which case I'll just turn my camera off again. All right. Okay, so thank you again so much for your presentation, and it was a great overview of our brain metastases. And if anybody has any questions in the chat, please feel free to drop them in there. But otherwise, I was just wondering how this field piqued your interest, Dr. Fouda, and how you found yourself in it.
It's a very interesting field, honestly, because it's when you look at the CNS classification in 2016 and the following CNS classification of the CNS tumors in 2021, you can realize the difference between how you uh, define the lesions based on the molecular biology. So based on the molecular profile, you can now find more targeted therapies and more like new ways for treatment as well. So it's not as before, it's just high grade versus low grade, or even like the classic definitions of high grade lesions or high grade gliomas. Now you have to think about like what is the molecular background telling you, because this is simply your next step for more advancement in treatment. So I believe this field is definitely moving too fast toward like more like breakthrough and like new treatments for patients with especially malignant brain tumors and brain metastases as well. And for brain metastases specifically, I think the major part is that the lack of like documentation of accurate numbers of the new cases, because we are not reporting them as we do in the primary lesions, in the primary CNS tumors. So I think the bottom line that we need some sort of national registration, as we do with the primary lesions, to get better idea and better understanding of the numbers and how many patients you would expect to have every year, and then linking the lesions with the primary lesions as well. I think that would be a major factor here. We can see like all the advances in the melanoma patient, in the melanoma treatments, and the BRAF inhibitors and these kind of things. This will increase the overall survival for the primary lesions and maybe improving the like the chances for these patients to survive as well as long as we can. So that's pretty much it. So I think just thinking about like having better national registries for these patients, thinking about like that, trying to find new solutions for the primary cancers as well may be helpful in this aspect for neurosurgical, like from a neurosurgical perspective. And the third thing is like that you need to follow up with these patients and document the follow up as long as you can. So you have longer follow up and you can have a better idea about like how these patients function over a span of 1 or 2 years.
Right, and from even an administration level, they would want to know the epidemiology of how frequent certain brain metastases are, so that they
Yeah,
can allocate resources accordingly. Is there a reason that you think these aren't recorded as well? Are they just not documented? Are they not coded by physicians? Is it a time
yeah,
consideration?
I think because it depends on how like how the clinical condition of the patient is um, at that point. So if you have a patient with like let's say um, melanoma patient who's like metastasizing everywhere, and you are like this patient is suffering, his family is suffering as well. Like they are coming to the hospital frequently, and you miss these things. Like we sometimes you miss these patients because you are not seeing them. So because no one is referring them to you as well. So it's very important to have people like to increase the awareness of people that you need to send these people to neurosurgery clinic to see what we can do for them and how we can just document like the status of their condition at that point. I think that would be like helpful as well. Uh, Having them like with sometimes most of times they are diagnosed after like the primary lesion, but sometimes as well you can diagnose them at the same time, which would be like a better option for you as a neurosurgeon to see them, and instead of like seeing them like after that. So I think from an administrative standpoint, it's very important to document these patients, because you can't ignore that they are 10 times more frequent than like the primary lesions. So you're talking about like the most common lesion in intracranial CNS2 in intracranial lesions. So this is the most common. So if you are not documenting the most common lesion, even if it's not primary lesion, even if it's not glioblastoma or meningioma, it's still like there are significant numbers of patients that need to be seen, examined, and finding like better option for them.
Of course, it can only help with outcomes to have that information and to do adequate research on it. And we always stress that research is so
Yeah.
important in neurosurgery, and this is just another, amazing example of it.
Yeah, and as I told you earlier, like for it's very simple that you have several studies that said like, okay, surgical intervention would improve the quality of life of this patient and increase the survival, but it's not like documented statistically, so that you don't have the required statistics to support your hypothesis here. Yes, you have promising numbers, but it's not powerful enough to like draw a conclusion and you say like, yes, if I intervene with these lesions, if I uh, resected them or these kind of things, yes, they have better outcome. You don't have the numbers to support this hypothesis. So doing more studies and recruiting more patients and reporting more data, that would be helpful for you to build like a solid conclusion that this kind of intervention will be helpful for these patients.
No, certainly. You said it's an extremely, even too fast. The field is rapidly advancing. And I feel
Yeah.
like this is just another component of it. Once we have that information and we can statistically back up some of that.
Yes, and sometimes even like the molecular biology of the primary lesion would change your vision and your perspective how you understanding the metastases itself. Because at the end of the day, this is a metastatic cell coming from a primary lesion. That's why when you look at the pathology report for melanoma metastatic brain tumors, brain lesion, or squamous cell carcinoma, or adenocarcinoma, or sarcomas, and every report is different from the other. So you're not dealing with one pathology here. You're dealing with different pathologies and different subtypes of lesions based on the primary lesion. So sometimes understanding the primary lesion will help you understand the metastatic lesion as well.
No, certainly. And I guess just as a segue to the treatment session, or rather the management session that we're going to be having next week, anecdotally, what percentage of your patients would you say are treated with chemotherapy versus radiation therapy versus maybe even just surgical intervention? Is there like a certain breakdown that you notice?
I think from an oncology standpoint, now the KPS scoring and like the RPA as well, they determine a lot of things when it comes to deciding which patient are going to be aggressive with treatment and which patient are going to be just like giving a palliative treatment. So it's a multifactorial like decision. You can't just build a decision based on like the numbers of lesions or like the accessibility of the lesions or if it's operable or not. And also there is a family say here, so it's not like 100% your decision as a physician. So now I think that the KPS score and the RPA classification will give you like at least an estimation of how you can imagine like a scheme for the management or for the next step based on the clinical picture of the patient, how advanced the disease is, like is there any other systemic lesions as well. So that all these factors contribute to this like decision. So you're not just making a decision based on yes, I can resect it or not. So also for the clinical presentation as well, this is something I just remember right now. It's very important to keep these patients in a good shape because sometimes this clinical finding, like clinical presentation at the time, if the patient has any mental status deterioration or cognitive impairment or any kind of symptoms and signs related to the brain lesion as well, sometimes these symptoms will ruin their chances to be enrolled in clinical trials for the primary disease, for the primary cancer. So That's another thing, because there are like in a lot of clinical trials for the primary cancer, you can think that there is certain eligibility criteria that the patient need to meet before being enrolled in these like trials. And if you want this patient to be or to have like the most objective outcomes from these clinical trials, you need to exclude any like kind of outliers of this trial as well. So you need to make sure that this patient is in good shape, in a good clinical condition. So presenting with clinical symptoms or signs that related to brain metastases because of like seizures or high ICP or these kind of symptoms and signs, at that point, this could ruin the chances of this patient to be enrolled in a clinical trial, which is also a burden, adding a burden to this patient and his family as well. So when you think about all these factors and all these variables all together at a point that this is how you want to make a decision when it comes to treating these patients, I think that's one of the things that you need to keep in mind when you make a decision.
No, of course, that's super fascinating because, of course, I mean, on the extremes of anything, if you're trying to get some type of normal population or some type of standard deviation, you're going to have to remove those extremes. But at the same time, and these are very sick patients, but
Yeah.
at the same time, you want to know about those sick patients to help inform how you're treating them. And have these scores changed a lot during your training? The guidelines that you follow, anything like that?
To the best of my knowledge, no. I think they are still the same. I think the KPS, like people used to use it for a very long time. I think the RPA is a new ad here, but that doesn't mean that it's like completely new. I think it's relatively new, but I think they were there like through my training as well. So, but it's not like a solid thing that you use for making a decision. It's just a helpful tool that you can make a decision based on it.
No, that makes a lot of sense. And then, if we don't have any questions from the chat, I just had one last question for you. Again, I'm thinking about other sessions that we're having. We're going to be talking about global neurosurgery, and I'm not sure if you had a chance recently to go back to Egypt where you did your medical school training. But do you know if the resources that they have there are similar to what you have here for the treatment of brain metastases, or if there's something that we can learn from the States over from what they're doing in Egypt?
I think what we miss in Egypt, and I think a lot of countries in the Middle East as well, that we don't have this concept of the multidisciplinary team. So when you see a patient in the neurosurgery clinic, it's completely separate from the oncology department. So you see a patient with an MRI with a lesion, you make a decision that if you can take the lesion out or not. And at that point, it's over. The next step, you are not that much in contact with other departments to know the progress of what's happening, unless it's an individual effort that you're contacting maybe a colleague or like another person in this department you're following on this patient specifically for your own reasons. But it's not institutional that there is like a tumor board like what we have here, or even what we had at Harvard or at Hopkins during my time there, that the decision is made collectively based on different expertise and different opinion from leaders in the field. But definitely they are dealing with a lot of work. They are dealing with a lot of patients. I think the training there is good from a standpoint of the quality of training. It's just a need some better logistics. But for the quality of the service itself, I think it's a good quality given you know the the infrastructure and the things that they have there. So given the situation and the circumstances they are working through, I think they are doing the best.
No, that's really fascinating, and it just makes it even more compelling for us here in the States, just thinking about all the different players who might be involved in a patient's care and how, in other countries, you might have to really take on that responsibility on your own, which I'm sure makes you an excellent physician. So that's fascinating to me.
Yeah, it's a pros and cons. Like you can't say like this is the reason why you could be a better physician because you are a single player. Because
Sure.
in this world, in this era, I don't think this is like a wise thing to do to be just a a single player. But I think the major difference between here and there is the team player. So it's like it's a team and everyone is working and contributing to this team, and it's all like it's all patient centered. So it's not that me or David or Ryan or whoever he is, like it's making the decision. It's actually us as a team making the decision. So I think that's the main difference between here and there.
Gotcha. All right. Well, thank you again, Dr. Fouda, for this excellent overview of brain metastases. We really appreciate your time, wonderful presentation. And for everybody else who's on the call, we are looking forward to seeing you next Tuesday for our management session. And be sure to tune into our events that are happening tomorrow and Thursday at 7 o'clock. All right.
Thank you so much. I appreciate the invite. And yeah, I wish everyone good luck and thank you for having me tonight.
All right. Our pleasure. Thank you so much, everyone. Have a good night.